Extract 2. Questions 13 to 24. For questions 13 to 24, complete the following notes with a word or short phrase.
Hello, Mrs. Peters. I see you made today's appointment because you are concerned about heavy periods. Is that correct?
Yes, Doctor, I'm really struggling with how heavy my periods are. I mean, it's reached a point where I can't even leave the house for the first 2 days, and I really can't afford to be taking so much time off work.
I see. That is quite an interruption to your day-to-day life. So, what you are describing is called menorrhagia, blood loss during your menstrual cycle that is significant enough to affect your life. So, let's get a clear medical history related to this problem.
Okay, where should we start?
How old were you when you started your periods?
I think I started my period when I was about 13.
Okay, so are your cycles consistent? And how often do you get your period?
Yes, they've always been quite okay. I bleed every 29 days on the dot, and they always last about 6 days. In fact, I just finished my last period. The first was 7 days ago.
And other than your periods being heavy, do you have any other problems with them? Any pain?
No, they're not particularly painful, and I've not had any other bleeding outside of my period.
And Mrs. Peters, I'll need to ask you a personal but related question. I hope you don't mind. But are you sexually active at this time?
Yes, I am. I have been married for a bit over 3 years, and I haven't had any other partners since I was married. I don't know if this was going to be your next question, but no, I've never been treated for an STI.
That was going to be my next question. So is there any chance you could be pregnant? Are you using contraception at the moment?
I was taking the pill, but I stopped using it about 6 months ago because we are trying for a baby.
So, a few last questions. When was your last cervical smear, and are you up to date with your smears?
My most recent cervical smear was 2.5 years ago, and they've all been normal. I've not had a letter for my next smear yet.
And in general, how would you describe your health lately? Are you more tired than usual, short of breath, changes in weight, problems sleeping?
No, I don't feel particularly tired, and my weight hasn't changed. Also, a no to fevers and night sweats or problem sleeping. I would say I'm otherwise well, and I haven't had to see a doctor for any other reason. Other than the pill, I'm not taking any medication at the moment.
Okay, so since your heavy menstrual bleeding is an isolated symptom and not related to pain, irregular cycles, sexual history, or intermenstrual bleeding, the most likely diagnosis is dysfunctional uterine bleeding.
And what causes that?
But your age makes fibroids less likely. I would like to do a few investigations. The first is a pregnancy test, which I'm sure you're on top of, but we need to rule it out. I would also like to check for anemia and do a transvaginal ultrasound to exclude local organic causes like fibroids, polyps, or adnexal masses.
And is there anything you can do to help me manage this problem?
Well, unfortunately, most of our management options for heavy menstrual bleeding also provide contraception, which are not appropriate in your case since you're trying to become pregnant. We do have one non-hormonal treatment we can try, tranexamic acid. It usually results in a 50% reduction in blood loss. You will need to wait until just before your next period to use it.
Okay, that sounds
Extract 1. Questions 1 to 12. For questions 1 to 12, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, Maria. How are you doing today?
I'm feeling pretty well, quite tired, but I think that is to be expected in my current condition.
Yes, of course. So you're at 24 weeks gestation, correct?
Yes, that's what I've been told, 24 weeks.
Yes, uterine size is appropriate for gestational age, and just to make sure we have your obstetric history correct, you vaginally delivered a 9-pound 8-ounce male infant 8 years ago.
Yes. Oh my, I hope this baby is a bit smaller than my son, 9 pounds 8 ounces. I had forgotten he was such a big baby.
And how is your son doing?
Oh, he's quite excited about the arrival of a new baby, though I suspect he will not be so excited once the baby finally arrives. He's in for a shock when it comes to all the crying and diapers.
Yes, I'm sure. And he is your only child, correct? You've had no other pregnancies?
Yes, only one pregnancy. I luckily have not had to deal with any miscarriages ever.
So, let's get a bit into your family medical history. I specifically want to talk about diabetes.
I see.
Do you have any immediate family members with type 2 diabetes?
Type 2 is the kind you get as an adult, right?
Yes, that's correct. Type 2 is sometimes called adult onset diabetes, though with childhood obesity becoming such a big problem, more and more kids and teens are also being diagnosed with type 2 diabetes. Type 2 diabetes is caused by a combination of genetic predisposition, being overweight, and a number of other factors.
Well, my husband has type 2 diabetes, and my mother too. My sister mentioned that she got tested for type 2 diabetes as well last year, but I'm not sure what became of that. She didn't say anything after, so I assume everything is all right.
Okay, so Maria, you have a first degree relative with the condition. So, Maria, I want to talk to you about your risk for diabetes. You have gained quite a bit of weight during this pregnancy, and a urine dipstick test showed that you have glycosuria, which is an abnormally high amount of sugar in the urine. Now, your test did come up negative for ketones, which is good because it shows that you do not have uncontrolled diabetes at this time.
Okay, I think I'm following you, but just to make sure, do I have diabetes or do I not have it?
At this time, you are a likely candidate for gestational diabetes. Gestational diabetes often disappears after giving birth, but considering your risk factors for developing type 2 diabetes, it may not go away. In fact, you may have been pre-diabetic prior to becoming pregnant. But with all the tests that are done during pregnancy, it's just being detected now.
So are there further tests you need to do or just some recommendations?
Since the urine dipstick test showed significant glycosuria, it is necessary to do some additional tests to confirm the diagnosis of gestational diabetes. You may or may not have it, so let's not jump the gun yet.
And if I do have it, I'd like to know just to mentally prepare myself. I want to be self-sufficient at all times and do not really like to be a burden on anyone.
Well, in the event that your results come back positive, the most important thing we will need to discuss is how you, as the patient, can learn to keep an eye on your own blood glucose. We also then talk about dietary and insulin therapy.
I see. What about my baby? Will my baby be affected?
Well, your baby may be born a bit on the heavier side. The extra glucose in your bloodstream triggers the baby's pancreas to make extra insulin, causing it to grow large. We will need to monitor the baby closely as well. It does also mean that the baby will have a higher risk of developing obesity, and then there is the likelihood of type 2 diabetes later in life.
Oh dear.
I'm afraid there may be some complications for you as well.
Yes, you mentioned diabetes already.
Yes, future diabetes and possibly high blood pressure. But the good thing is that we caught it now and not later, so we can start working on getting it under control.
Yes, I mean, I thought I was just coming in for a routine appointment, but
That is the end of Part A. Now look at Part B.
Part B. In this part of the test, you will hear 6 different extracts. In each extract, you will hear people talking in a different healthcare environment. For questions 25 to 30, choose the answer A, B or C, which fits best according to what you hear. You will have time to read each question before you listen to the audio. Complete the answers as you listen to the audio.
Now look at question 25. You hear a nurse briefing her colleague about a patient. Now read the question.
Mr. Jackson came into the A&E last night complaining of shortness of breath and a dry cough. He also presented with a high fever. At the time, he was found to be severely dehydrated and also very disorientated in time, place and person. He was then admitted after a chest x-ray suggested atypical pneumonia, and investigations of his arterial blood gases on air showed hypoxia. The current diagnosis is community-acquired pneumonia. He was put on high concentration of inspired oxygen and also intravenous fluids to correct his dehydration, and then later on antibiotics, a combination of cefuroxime and clarithromycin. The results of the investigations to make a microbiological diagnosis should be available soon, and at that time the antibiotics can be adjusted accordingly. At this point, he has not required mechanical ventilation, but it is a possibility.
Question 26. You hear the ward leader talking to the nursing staff. Now read the question.
Now, a quick word about the reporting of errors. As we have previously discussed, reporting errors is fundamental to error prevention. I know that we all recognize the importance of reporting errors that can lead to death or grave harm, but reporting potentially harmful errors that were intercepted before harm was done, errors that did not cause harm, and near-miss errors is as important as reporting the ones that do harm patients. Improvement efforts that target systems-related failures that contribute to errors within the complex environment of healthcare may fail if many errors are never reported or captured through other mechanisms. With this being said, I, along with other ward leaders, have noticed a drop in the number of errors being voluntarily reported. In fact, reports of errors have dropped by 40% in the last month, which on the surface may sound great, but as I just pointed out, is an area of concern. So,
Question 27. You hear part of a morning briefing on a hospital ward. Now read the question.
right, so now to overnight admissions to the ward. Susan, could you start us off?
Sure. We have Jeanette Evans in bed 4. She's a 46-year-old woman brought into the A&E with right-sided loin pain and macroscopic hematuria. She was diagnosed with autosomal dominant polycystic kidney disease, and a long-term treatment plan for her is currently being developed. Now that her symptoms have been stabilised, she's going to be transferred from high dependency unit to another ward.
Okay, I'll review the clinical status this afternoon and coordinate with the other ward leader for her transfer.
Her family will be around later today, and social work intervention is recommended to help them with long-term support of the patient, as well as to help coordinate screening for them.
Question 28. You hear part of a post-surgery follow-up at a GP practice. Now read the question.
Mr. Alex, how are you today? Things going smoothly since the procedure?
Yes, I mean I'm sore, but feeling better.
So, you had a laparoscopic appendectomy, so there should be little or no scarring. So, let me check your abdomen. So, I can see the tiny incision points, but there is no sign of infection. So, have you experienced any pain?
I feel a little pain in my belly, but it's getting better each day. My doctor warned me about it.
Yes, that's likely due to the carbon dioxide gas still in your belly. So, everything looks like it is going well. Do you have any questions?
I wanted to know when I can get back to my normal routine.
So, you are now 3 days post-op, so you will need to wait at least another 5 to 6 days before getting back to your normal routine. But be sure to take it slow at first so that
question 29, you hear a trainee doctor telling his supervisor about a problem he had with a patient. Now read the question.
So how has today been so far, James?
Well, not so great. I was checking on the patient in bed 6, Mr. Johnson, and realised he was showing signs of dehydration, so I decided I needed to put in an IV to deliver fluids. It is a procedure I've done on numerous occasions, but I just couldn't find a vein. Do you think his long stay here has led to collapsed veins?
Well, that can happen with patients like Mr. Johnson. Chronic health issues resulting in long stays in medical facilities and hospitals. And as you can imagine, it is stressful for them if the procedure isn't completed quickly.
Yeah, he tried his best not to complain. I could tell he was uncomfortable.
How about next time I supervise you do it?
Question 30. You hear a doctor talking to an athlete with a painful arm. Now read the question.
Now then, I understand that you're experiencing some discomfort in your right elbow.
Yeah, it started out just as an ache that would get better once I warmed up, but now there is constant pain on the outside of the lower portion of my right arm, as well as on the outer bony point of the right elbow.
Do you recall any injury or triggering event?
No, not at all. I have noticed that the severity of pain increases when lifting any heavy bag, when sleeping on my right side, and also while bowling. I'm a competitive bowler. I hope I can get back to competition soon. Do you think?
So, it sounds like you have a classic case of lateral epicondylitis, but there also appears to be some weakness of your scapular stabilizer muscles and the arm and forearm muscles. There are a number of exercises and treatments too.
That is the end of Part B. Now look at Part C.
Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about specific aspects of their work. For questions 31 to 42, choose the answer A, B or C, which fits best according to what you hear. Complete the answers as you listen to the audio. Now look at Extract 1. Extract 1. Questions 31 to 36.
You hear part of an interview with a doctor called Dr. Ellen Samuels, an expert on Lyme disease. You now have 90 seconds to read questions 31 to 36.
So today we're talking to Dr. Ellen Samuels, a professor of laboratory medicine and director of the Viral Diagnostics and Discovery Center in the USA. Dr. Samuels' recent reports show that Lyme disease is on the rise. Why do you think that is?
You're quite right. Earlier this month, the US Centers for Disease Control and Prevention reported that cases of tick-borne disease more than doubled from 2004 to 2016, from 22,000 cases to 48,000, and that Lyme disease accounted for 82% of all tick-borne diseases. Also, it's important to point out that despite the increase, it is suspected that because of underreporting, the actual number of Lyme disease cases is actually significantly higher, likely more than 350,000 in 2016. As far as why rates have increased across the US, one reason is globalization. People today travel extensively, and for instance, someone can get infected on the East Coast and then go back to their home on the West Coast with Lyme disease. Another reason is climate change, in that the geographic range of the tick vector has expanded westward from the northeast region of the country, as well as southward year after year.
How interesting. Non-clinical reasons driving the increase in infections.
Yes, exactly.
So, how exactly is Lyme disease transmitted? And I hope you don't mind, but another related question is it contagious between humans?
So, for ticks to survive in nature, they need to have what we call an animal reservoir. Essentially, a mammal such as a squirrel or rodent that can harbour Borrelia burgdorferi, the bacterium in the tick that causes Lyme disease. So the cycle continues when ticks feed on those animal reservoirs carrying Borrelia burgdorferi, and then more ticks get infected. Then the ticks can then transmit the infection to humans. Fortunately, the efficiency of transmitting the bacterium from human to human is quite low. I mean, the period during which you can find the bacterium in blood is very brief, a few days at most, and blood-borne transmission of Borrelia burgdorferi, such as by transfusion, has never been reported. The bacterium is also not excreted in other bodily fluids such as sweat, urine, saliva, or respiratory secretions. For those reasons, Lyme disease is not considered contagious.
Much has been made of the difficulty involved in detecting and diagnosing Lyme disease. Is that true?
Yes, it does appear that Lyme disease is harder to diagnose, and it's primarily because Borrelia burgdorferi very rapidly leaves the blood and disseminates into the lymph nodes and into tissues. As a result, blood tests for early Lyme disease have low sensitivity.
And is it true that it takes at least 24 hours for a tick to transmit Lyme disease to a person?
Yes, that's true. The CDC recommends that patients who notice the tick and remove it within 24 hours do not need antibiotic prophylaxis with doxycycline to prevent Lyme disease transmission. The tick typically needs to be on you, sucking your blood and attached to you for 36 to 48 hours, during which time the bacterium migrates from the tick gut to its salivary glands and transmits the Lyme pathogen.
Just a moment ago, you spoke about the low sensitivity of blood tests. So, how accurate are the current diagnostic tests for Lyme disease?
The current approved testing for Lyme disease is a two-tier serologic test that looks for the generation of antibodies in response to the infection. However, the key limitation of this test in early Lyme disease is that typically an infected individual may take several weeks before he or she is able to mount an antibody response. Once an antibody response is mounted, the two-tiered serological test tends to be very sensitive.
Is that why so many cases remain undiagnosed?
Yes, we do not have an accurate test for early Lyme disease. My lab is currently working on better diagnostics for Lyme disease. A couple of years ago, we did RNA sequencing of blood samples from patients with Lyme disease to look at the human host response. We looked closely at the pattern of gene expressions in patients following infection, comparing the gene signature of Lyme disease to that for control patients. We found that Lyme disease, interestingly enough, has a very distinct pattern of human gene expression in response to the infection. We're currently using these findings to develop a test to more accurately diagnose early Lyme disease.
And once a patient has been diagnosed with Lyme disease, what is currently the best standard of care for treatment?
Well, the standard of care.
Now look at Extract 2. Questions 37 to 42.
You hear a psychiatrist called Dr. Matthew Andrews giving a presentation to a group of GPs. You now have 90 seconds to read questions 37 to 42.
Hi, my name's Matthew Andrews, and I'm a psychiatrist working with child and adolescent mental health services here in London. Today, I'm going to present the results of a research study to show you a new way forward for collaboration between general practitioners and specialists in child and adolescent mental health. So, before I get into the study, let's get into the importance of GPs in child and adolescent mental health care. Research has shown that an interested GP is in a good position to provide services to children and adolescents with mental health problems. However, many GPs believe that they lack specific knowledge in this area. Just to show you the mismatch between opportunity and knowledge, a study found that approximately 80% of children and adolescents with psychological problems have seen their GP within the last year, but GP's identification of psychological problems was limited. These findings are consistent with other studies. This clearly points to a need for GPs from a consultative role only for a psychiatrist to specialist clinics in a primary care setting, telepsychiatry to collaborate care with various mental health care providers. Generally, collaborative programs seem to be more effective than theoretical educational programs, with joint consultation found to be particularly effective. One important fact to point out about these collaborations is that they have generally taken place in adult psychiatry or in pediatrics, but not in general practice. So, since joint consultations in other contexts have been useful, we thought it would be interesting to see how a similar approach would work in general practice. In particular, the aim of our study was to evaluate possible benefits and downsides of the collaboration so as to make useful recommendations to other GPs and mental health specialists considering implementing something similar. The joint collaborations that were the focus of the study took place at the GP's office at a local health centre. When there was a concern about the psychological health of a child or adolescent, the GP could make a joint appointment with one of the participating child psychiatry specialists. Every fortnight, GPs had 2 available 1-hour appointments. Before each appointment, the GP and child psychiatry specialist would usually have a brief talk before the GP fetched the family from the waiting room. Then the GP would start the appointment by presenting the visiting specialist to the parents and child and informing them about the collaboration. Next, the child psychiatry specialist would take the lead in establishing contact with the child and the parents. The general purpose of the consultations was to decide whether the child required a referral or if the problem could be handled in primary care, whether by the GP, school psychology services, child welfare services, or others. After approximately 100 joint consultations had been held, the next phase of this project was started. The next phase consisted of a qualitative study based on focus group interviews, one interview with GPs and another with participating specialists, psychiatrists, and psychologists. So the focus group discussions revealed that both GPs and mental health specialists see joint consultations as a good teaching method for improving GP skills in child and adolescent psychiatry. For example, the GP said that they had learned a great deal from seeing how the specialist talked with the children. They also pointed out that they had received concrete advice and learned strategies to use when treating such conditions as phobias and sleeping disorders, and they would feel comfortable using the strategies on their own with future cases. The child psychiatry specialists also gained insight into the way a GP works, as well as benefiting from seeing a broader range of patients and from obtaining some somatic knowledge, particularly for those who didn't have broad medical training. They also found in the end that they were getting fewer referrals from the GPs, and that the referrals that did come were more appropriate. Specifically, the child psychology specialists said that they felt confident that GPs could handle more cases on their own. In general, both groups believed that this low threshold service benefits the patients, and the joint consultation is especially suited to sort problems and determine the level of help required, and that That is the end of Part C. You now have 2 minutes to check your answers.